Hi, this is Scott Miller. Welcome to the Top Performance Blog. Today, I have the distinct pleasure of speaking with a psychologist, a colleague, someone I consider a friend, Dr. Ed Jones. Hi, Ed.
Hi.
Thanks
Good morning.
for agreeing to this particular interview for my blog.
Yeah, I'm happy to do it.
You know, Ed, I've known you for well over 20 years, and I have to say that you're somebody who is aware of trends. Long before it was fashionable or popular, you had picked up this idea that therapists were going to have to measure their outcomes. And so an organization that you led was really organized around that particular idea. And it led to a whole bunch of innovation and success. You've since moved on. You're running a consulting firm, ERJ Consulting, out of Los Angeles. Did I get that right?
That's right. Yeah, very fancy.
And in our field's history, in my looking back over it, there have been several key moments, what I might call disruptions of the status quo, the way things had been, the things that we'd gotten used to. Perhaps the first one was when the entire idea of talk therapy became popular back in the late 1800s, early 1900s. I don't think we remember just how revolutionary that was. We had an entire episode of a podcast, episode 4, that Dan Lewis and I did on that very subject. Then some 50 years or so after that, we had Hans Eysenck and the challenge he gave to the field about the evidence for our claims that talking with people actually helped. And it really was the birth, in my estimation, of psychotherapy outcome research. A few more decades passed and managed care reared its head. I know you and I were both around during that particular time.
Oh, yeah.
And you can't say that it didn't affect virtually all practitioners. It really did. And it had been predicted by another disruptor, Nick Cummings, who was responsible for developing professional schools of psychology. He was a president of the APA. He helped APA turn from a group of researchers really to a focus on clinicians. And then in a 1980 article in AP, he said, managed care is coming. And as clinicians, we could either be at the forefront of that, maybe even develop our own way of paying for services, or we could become, and I can remember the quote, it stuck with me over that many years ago. He said, poorly paid, little respected employees of giant healthcare corporations.
Yikes.
And in a way, I don't know, many of us may feel that way, that our private practice is a shrinking entity since about that time. There was the biological model in the 90s, and now there's something else on the horizon. And that's when I reached out to you, and lo and behold, you'd been writing about that. And whether you agree or disagree with this trend, your words are, it's coming.
Right. That's
What
right.
is it, Ed? What is it?
Well, the it is, in my words, the future is medical. What that means is we have been experiencing for a number of years a consolidation in the general healthcare industry, right? We know that there are only a few health plans now. We know that there are enormous health systems. We also know that all of the once independent carve-out behavioral healthcare companies have been consumed. They're now part of the health plan. So this consolidation has been going on, and my focus is on the business trends that impact what we do. Well, it's one of those things where very often things that are important and things that are urgent are in different sectors. There's an incredibly important development of the medicalization of everything. And we're focused on more urgent matters like paying our bills and so on. And what I've been writing about lately is that we really need to focus on the fact that our survival is going to require us to fit into the general landscape of healthcare in ways that we haven't really been thinking about. And it's going to require us to modify what we do. To put it less generally and to be more specific, I think we have to do a better job of integrating with primary care and making our services much shorter than the 50-minute hour.
So psychotherapy as an entity, not going to disappear, but
No.
it's certainly going to change. And a couple of things you've highlighted are that it's likely to be delivered more and more, if it is delivered at all, in the walls of a physician's office or a healthcare system's office.
That's already started to some extent. And I'm a big advocate for promoting that even more and thinking about it in ways that people are not today. I don't
Mm,
think that the way that therapy has been integrated into primary care today is very good. I
mm.
mean, it's still operating with send the therapist a referral now and then to do some therapy with somebody who randomly popped up as needing it. I think we need something a lot different than that. But what I would say is there are a lot of things going on. Digital healthcare is, as you know, huge. And what's happened is that some of the techniques of psychotherapy have been digitized. And we have these new companies that have had billions of dollars invested in them. And they got started with the idea that they would be supplemental to psychotherapy. But my concern is that when the marketplace takes over, cheap digital access to therapeutic tools online could be offered, and they could be offered instead of therapy. And that's what my main concern is, that people are not preparing for that. And I think it's going to hit like a ton of bricks.
Wow. So I'm going to put some links to some of the articles that you've published about this, but can we get more specific? What does this actually mean? What does this look like? So you go to your physician, right now they write out a script, you go to the pharmacist, they give you a pill. Does this mean that the physician is going to write out a link to a website instead of sending the therapist, or is it, what does it look like and what can we do?
I think that the first thing for me to say is I have no idea.
Okay.
I'm not a person who makes a living predicting the future. What I do know is that an awful lot has been invested in digital tools. They do help a lot of people, and they're going to find their way into the continuum of services. Whether that's going to be literally that clinicians like primary care docs are going to be recommending them, whether they'll be promoted by the office staff, or they'll be promoted by your health plan. I mean, health plans are going to drive a lot of this. Let's not forget that.
Hmm.
They'll be promoted in a big way. What I'm suggesting is that another good person to promote this would be a therapist.
Hmm.
A therapist who spends 10 minutes, whatever it may be, 10, 15 minutes with a person who's got a range of issues. Again, I don't think I need to go on and belabor the point that the range of behavioral issues in primary care are vast.
Hmm.
So the need is enormous. And what I would argue is it can't be we do long psychotherapy sessions with everybody. That's not going to work, and people don't want it. But what we can do is we can operate in a very different environment. It's called a longitudinal environment. People see a primary care doc very often for many, many years. Well, psychotherapy as one of the services that's being provided within the primary care setting would function on that timeline as well. And so you don't see people for long sessions. Maybe you plant some seeds. Maybe you get people thinking about things and you see them again in 6 months or a year. But the point is, we have to be thinking about how could that really work effectively.
So we're not just thinking about the numbers of sessions, but you're talking about sessions that may be on the same length of a physician's visit, from 7 to 15 minutes, and being
That's right.
able to have impact within that period of time.
That's exactly right. The fact that a lot of people have never had the experience of talking with someone who is empathic, non-judgmental, who will listen to them. The greatest complaint in medicine is that the doctor doesn't listen.
Right.
I mean, it's number one. Primary care docs, they know they need help. I think that they are very open to the notion that behavioral issues are just primary, and that behavior change is the missing ingredient to their being able to help many of their patients. The future is medical.
Your statement, the future is medical, would it be more accurate linguistically to say the future is within the medical realm,
I
as
think
opposed
that's
to,
accurate. Yeah. Yeah,
Uh,
in other words, I don't want to say that it's medical as in we're going to be medicalized, we're going to be under the thumb of the medical establishment. We have to find our way within the medical system to help patients, to help doctors, and to help ourselves.
hmm. The second thing that occurs to me, and let me just state the bottom line first and then come back and
Sure.
explain a bit of my thinking here. Technique contributes the least amount
Yeah.
to outcome. It is in our field of psychotherapy already the factor that gets the most attention. It's what graduate school programs focus on. It's what continuing education
Right.
workshops teach. And it's frankly what therapists privately think causes change in psychotherapy.
Right.
They may say, oh, no, it's about the relationship. But when you
Right.
ask them privately,
Yeah.
they actually think it's their expert use of technique, all of which is not in line with the outcome data. Now you're saying we're going to have 15 minutes, maybe 10, maybe 7 within a consultation. And won't that cause us to rely, much like a physician would turn to their prescription pad rather than to listening to solve this particular problem?
Yeah.
I'm interested in your first impressions.
I think that you're exactly right. And that would be the very first thing to guard against. In fact, the best evidence for that is what's happening today when you see therapists being hired within primary care settings. There was a job listing some months ago, and it was looking for a therapist to be full time in a primary care clinic. And what the job basically said is, we want you to be a junior psychiatrist. We want you to go around and find out who needs medicine. We want you to talk to the patients about what side effects they might get from the medicine. We want you to diagnose things that maybe no one else is seeing: depression, anxiety, substance use. We'd like you to coordinate. I could go on and on and on. I mean, I don't know who would take a job like that. My attitude is, if I get to train people, my attitude is go in and be with the person. And I think that we have to take that and be true to that when we go into the medical setting, as I suspect we should and will have to.
I know that, and what gives me a bit of hope that we can do that if we're aware of the disruption that's about to come, is some research on physicians, actually. I think that the patient actually talks about 17 seconds, I think is what I read, before they're interrupted by the physician during a regular office visit. And in some ungodly number of cases, they never get the floor back. That is the patient.
Right.
The physician who's under the pressure you describe thinks that they're going to cut to the chase and get to what really matters. The patient doesn't feel heard, and as a result, they tend to call back
That's right.
and look for more help.
That's
What
right.
I have noticed is a trend, even in my own healthcare interactions with physicians in the last few years, of spending time listening to me before we finally get to the treatment, whatever it's
Right.
going to be. And
Right.
I have to say, it really does make a difference. I don't
Right.
feel the need to call back, et cetera. So I am hopeful that it can be taught and done.
I think it's critical. And I've spoken with a lot of primary care docs. And what the doc will tell you is that they don't want to get into our areas because they don't know what to do with it. The problem on our side is we're good at letting people talk. Well, I'm telling you, you only got 10, 15 minutes. So you better figure out a different strategy than just saying, tell me about what's going on in your life, and then sitting back and saying nothing for 15 minutes. That's not going to be
Right.
a very effective strategy either. But again, I point to warning signs, and then I turn it over to people like you to kind of figure out what the heck would a good therapist do in a situation like that.
Yeah, and I'm not going to let you off the hook that easy. So here's my question, because you did have a long and very successful experience implementing what was then a pretty revolutionary idea that we should measure our outcomes. We might want to direct clients to clinicians who had better outcomes.
Right.
We might give feedback to the clinicians so that they could respond more effectively. What barriers did you see in clinicians' behavior or their thinking that got in the way of adopting what really is becoming a standard of care?
A couple things. One is that it was interfering with the work that they felt was most important. So I always understood why somebody would treat it as being a pain. I think that there were issues of there not being consequences one way or another. So if something doesn't matter, why would you do it?
Hmm.
That's pretty simple.
Hmm.
I don't think people understood it. I think that people, by and large, thought it was all bogus. Certainly, I was introducing it from the vantage point of managed care. And so we had about zero trust.
Hmm.
So there was that. So I think that if you think about it, it really takes people within your field to champion the idea.
Hmm.
I think that it really requires people who are trusted to say, no, this is actually valuable. For me, I didn't come along and invent the idea of outcomes. I listened to the great minds that were within our universities and in our clinics who were doing therapy and research and had identified this as being critical to good care.
Hmm.
The other part of my answer would be this: you need people willing like me to step into business. In other words, I'm all for people just honing in on getting better and better at therapy. I also think we need people in our field who are willing to take on business challenges. If we get a good wave, as you say, of young people who have a fire in their belly and who say, no, I'm going to turn the field in a direction that I think is right. It's good for everybody who's a stakeholder. And I'm gonna tackle these business issues. It can be done. It's not insurmountable. I
Hmm.
just think that we need people willing to dive into that end of it too.
It's interesting, Ed. I've said before to colleagues that the biggest piece of malpractice in my education as a psychologist was the absence of a single, not even one business course.
Yeah,
Not how to even at the time run a private practice or
right,
get a job. None of
right.
that. But interestingly enough, what I keep hearing over and over, while I think I represent the side of fear with these coming disruptions, to be frank and
Yeah,
honest, you're optimistic. It
right,
can be done.
right.
It can be fixed. We've just got to step up to the table. And one thing I think about that is a remarkable opportunity when I look at the data about how most people get into therapy, how most people with a need get into therapy, they don't say, I looked on the internet to find the right therapist.
Right.
What they say is, I talked to family and friends, and right up there in the top was, I talked to my physician.
That's right. That's right.
And so if we're there,
Yeah,
not only in the physician's mind as a potential referral, but in the office of these large healthcare settings, one real big benefit is more people are likely to get the
yeah.
mental health care that they could benefit from.
I think that's huge. And let me tee off of that in a different direction. The reason I'm optimistic is that I think that people want help. And I think that our patients, our future patients, our clients, whatever word you like, all of us, right? We're going to push for what we want and what we need. And I really do think that the best way to eradicate the stigma that is still very strong, it's still alive. I mean, I read articles that drive me crazy about how it's so much better and this, that, and the other thing. The only way we're really going to, I think, address it is not by medicalizing everything. I mean, psychiatry's answer to stigma has been, well, just assure everybody that they have a disease just like everybody, just like any other.
Hmm.
And I'm fine with that. I'm not critical of that so much as I think it's doing an injustice to so many other people who need therapy, who need help. It may be brief, it may be more extended, whatever it is. The only way we're going to break down the barrier of stigma is by putting it right into healthcare. You can say whatever you want, the words are fine, but when you find a therapist at the doctor's office, when you go into your primary care doctor and the therapist is there, when behavioral health care is not some specialty off in a private office, you're going to be breaking down barriers and you're going to get the tremendous pent up need and the forces of clients who want help. They'll be the leading edge and we can just move in there behind them.
Wow. Well, on that note, Ed, thanks very much. I really appreciate your vision here to help us address this upcoming disruption and seeing what this could do in terms of helping people in need. Thanks so much.
Well, great. Thank you. Take care.
If I search, will